kick us off.
Great. Thank you, Naomi, and welcome to everyone. Thank you for joining this IHEA webinar, which has been organized by the Special Interest Group on Equity Informative Economic Evaluations. We have most of our co-conveners here, and many thanks to IHEA as well for supporting this today. This is special webinar. It really reflects the growing interest in addressing equity through research as well. And today's topic is to look at PhDs with an interest in using equity informative economic evaluations. Before we get started, just a few housekeeping points. First, we request you to keep your microphones on mute while there are presentations going on. We would like this to be interactive. And in case you want to raise any points, please feel free to raise your hand with the Zoom function, or alternatively, please put in your comments on chat. Also, as you may have consented already, please note that this webinar is going to be recorded and will be made available for others to view later. So, as Naomi said at the start, this is an important start to our engagement on equity, and seeing the participation here from across the globe, we are really encouraged to take this forward. So first objective is that we would like to hear from 2 doctoral students about their experiences with incorporating equity in their research. And the second is really to hear from all of you and see how we can really take this field forward and hopefully create some networks that will go beyond this webinar as well. We have 1 hour ahead of us, and as I close this introductory section, I'll then hand over to our first presenter, James Oguta, who will be presenting on his study on health, economic, and the equity impact of cardiovascular disease prevention in Kenya. After his presentation, we will move quickly to Katherine Snyman, who will speak about her PhD research on economic evaluations of novel malaria vector control strategies in Uganda. After which we shall try to have small group discussions for about 20 minutes, where we hope we'll have a chance to share and really cross-pollinate ideas and draw on the experiences of our presenters before we come back together in a plenary discussion and have closing remarks by Naomi. So without further ado, I'd like to introduce our first speaker, James Oguta, who is studying for his PhD at the University of Sheffield. I understand he'll be also sharing more about himself. So over to you, James. I understand you'd like to share your own slides, or please let me know.
Thank you, Sauda. Can you confirm that you can hear me okay?
Yes.
As I load the presentation, please. Yeah, thank you. Thank you. Yeah, can you confirm that you can see the slides?
Yes.
The slideshow?
You can. Yes.
Thank you. Thank you. So, as Sauda has mentioned, my name is James, PhD student at the University of Sheffield. On a Wellcome Transfunded program in Public Health Economics and Decision Science. I've worked in global health, mostly in low and middle income countries for over 15 years, with the latest experience at UNICEF as a health economist supporting 21 countries in sub-Saharan Africa. I'm passionate about the attainment of universal health coverage in low and middle income countries, especially on issues around financial risk protection for households, to avert illness-related impoverishment. My PhD project is on cardiovascular disease prevention in Kenya, and as you may know, cardiovascular diseases are the leading contributors of global mortality and morbidity, and low and middle income countries, especially in Africa and Asia, are the most affected, as you can see from this tile to the left. In sub-Saharan Africa, most of the regions have the burden of disease, which falls within like the 50th percentile of all regions. So this graph on the left shows that the lowest region or the region with the lowest burden is Eastern Sub-Saharan Africa, and they all fall in the first half of all burden of disease across all regions. This graph to the right shows in the middle we have cardiovascular disease, and that's a light blue colored tile. And as you can see, both globally and in all regions of sub-Saharan Africa, cardiovascular diseases are the leading. Now, hypertension is the single largest modifiable risk factor for NCD for cardiovascular disease, and has in sub-Saharan Africa especially, there is the region has one of the highest burdens of hypertensive heart disease, and as you can see from this graph, and then Kenya is located in eastern part of Africa, where my cursor is pointing at, and so the health, similar to what we have seen before, cardiovascular diseases are still the leading causes of NCD deaths. And NCDs are distributed in different parts based on social demographic characteristics. We observe that the magnitude or the burden of disease is more concentrated towards the central region counties. Kenya has a devolved system of government with 47 semi-autonomous regions or counties, and one national government. So most of the health care function, especially primary health care, is a function of county health, county governments. The main problem is a low, poor utilization, access and utilization of cardiovascular disease risk factor screening and treatment interventions across the population. And data from the 2015 STEP survey report that less than half of the Kenyan population, that's adult population, has been screened for hypertension, and about 1 in 10 screened for diabetes, that is elevated blood sugar, and even much less for hyperlipidemia based on these statistics. And out of that, even a lesser number, like 1 in 5 initiated on treatment, and about half of that number again attaining blood pressure control. This means that if nothing is done, then that poses a big risk. Inequalities also exist, with as much as 3/4 of the poorest quintile never having been screened for blood pressure, compared to about 40% in the richest quintile. There is also a very significant out-of-pocket spending attributed to NCD. So my PhD project comes in to examine the health, economic, and equity impact of cardiovascular disease prevention in Kenya, using an existing multi-component community-based hypertension and diabetes screening and management intervention that is called Empower Health. And Empower Health as a strong digital health component implemented by the Ministry of Health currently across 9 counties, that's 94 health facilities, and has enrolled about 76,000 patients since 2019 when it started. So patients are enrolled and followed up as they go through different clinic visits. Currently, the intervention is scheduled for scale up to 35 additional counties. Meditronic labs, and I'm glad that Dr. Oren Ombiro is in this call, currently supports that intervention, the government of Kenya, to implement the intervention through a digital health platform that is called SPICE. So these are the different components of the intervention, ranging from screening to follow-up and personalized care plans, e-prescription, and so on and so forth. So my project has three main objectives. The modeling part, that's evaluating the relative cost effectiveness and budget impact of Empower Health as an intervention compared to usual care or standard of care that is currently implemented in Kenya. And I also intend to examine the financial risk protection benefits of scaling up the intervention in terms of to what extent would this intervention avert or alleviate household poverty. And then I will also, I'm also interested in focusing on other equity impacts of the intervention. So this is an overview of the methods that I intend to use. The first part is complete. I've done 2 systematic reviews. The first one is on decision analytic models for cardiovascular disease prevention in sub-Saharan Africa. And as part of that, I looked at how these models that have been published have modeled equity metrics, or have incorporated equity considerations. And I'm also finalizing a second review on that is specific to the application of model-based evaluations to community-based hypertension intervention in low and mid-income countries. The next phase of this project involves conceptual modeling that has a strong component of stakeholder engagement, and that's already starting from next week. I am thinking about a microsimulation model given the nature of the intervention, existing taxonomies. I think you may have come across Brennan taxonomy that has been updated by Briggs and Penny, Breeze, and to look at financial risk protection impacts of the intervention. I will use extended cost effectiveness analysis methodology, which would be would look at the financial risk protection brought by that intervention. Other equity analysis, I'm thinking about subgroup analysis at the very least, but if time allows, then I'll consider doing a full distributional cost effectiveness analysis. Some of the outcomes from my model, DALIs, of course, cardiovascular disease cases averted by the intervention, deaths, cost saved, household out-of-pocket spending averted, catastrophic health spending, and finally, manimetric value of insurance that is provided by intervention scalar, different scenarios. More in-depth about the methods, I'm thinking about using the Kenya State Survey to construct my synthetic population that I'll use for the modeling, and then, of course, incorporating bits of iterative proportional fitting for reweighting that to compute the 10-year CVD risk. I'll use the WHO risk algorithm for Eastern Sub-Saharan Africa, of course, with sensitivity analysis using the global risk and Framingham equations. I'll also, given that this data set only has an intervention arm, so I'm thinking about the use of suitable causal inference methods to generate a counterfactual, especially to model the usual care arm. This will be done, the modeling will be done in R or Python. That is to be decided upon depending on the final conceptual model. And of course, uncertainty analysis will be done, will be corrected by looking at performing different sensitivity analysis, including value of information methods. So this slide summarizes the steps of conducting extended cost effectiveness analysis that first starts with computing the health gains from the intervention to the costs that would be averted, and finally the financial risk protection across different quintiles. And The next slide is just a summary of the different work packages. The first two have been done, which are reviews, and the next phases are ongoing, as already mentioned previously. I would like to acknowledge my supervisors who are all in the call now. Dr. Oren Ombiro is here. The Ministry of Health, led by Gladwell, been very supportive. Kenya Cardiac Society, Dr. Lillian Bau, and finally, Professor Stefan Verguen, who is also here for his technical review. And yeah, finally, Wellcome Trust for the funding. So thank you very much. In case you have any questions, that's my email address. Feel free to drop it and we can pick it up from there. Thank you. Thank you.
Thank you so much, James. And really great to see this work getting started and to see all your supervisors and colleagues also join the call. Since we'd like to keep the momentum, let's move on to our next speaker for this evening, Katherine Snyman. She's currently a PhD student at the London School of Hygiene and Tropical Medicine. She has been working on economics of malaria, as well as on equity informative economic evaluation, and focused on working in low income settings. So perhaps I'll hand over to you, Katherine, if that's fine.
Great, thanks. Can I also share my screen? Yeah, great.
Please.
Okay, can everybody see my slides?
Yes.
Okay, great. All right, hi, my name is Katherine Snyman, and I'll be talking to you about some of my PhD work. My thesis is titled Economic Evaluations of Novel Malaria Vector Control Strategies in Uganda, Assessment of Costs, Effectiveness, and Equity. So I'm going to give a pretty high level overview of some of the different methods I've used or plan on using in my thesis, but I have two main questions that I hope you'll keep in mind throughout the presentation. Why and how can you incorporate equity into your PhD? First, I'll give a little background about myself. I've come to health economics from a public health background. I hold a master's in global health and environment from UC Berkeley, and I've been based in Uganda for 10 years, working on malaria and HIV clinical trials with the University of California. I started as a part-time student at London School of Hygiene and Tropical Medicine 4 years ago, and I'm in the data analysis and writing stage of my PhD, and hopefully, knock on wood, I will complete in 2024. And as mentioned before, here's my thesis title. So malaria is a disease transmitted by mosquitoes and is the 5th leading cause of death in lower and middle income countries. Uganda has the 3rd highest number of cases worldwide. Just as malaria is not distributed equally throughout the world, the burden of malaria is borne by the rural and poorer populations of Uganda. Globally, malarial incidence and deaths fell rapidly from 2000 to 2015. However, these rates have plateaued since, and there's a concern that insecticide and drug resistance are rendering current control tools less effective. So to address these gaps, several novel vector control interventions have been developed, including housing modification and next generation LLINs, or long-lasting insecticidal nets. My PhD work is embedded in 2 cluster randomized control trials evaluating 2 such interventions, and it's taking place in Uganda. The first is the Uganda Housing Modification Study, and that's comparing the impact of 2 different housing modifications. The first is screening, so screening of all openings such as windows, vents, and eaves. And the second is eave tubes, which are tubes fitted with insecticide-coated mesh inserts that are installed in the home's boundary walls. The second project is the Lineup 2 project, and it's evaluating the impact of next generation long-lasting insecticide-treated nets. So basically, this is just a new formulation of insecticides that are applied to bed nets. And these were distributed during the 2020 National Universal Coverage Campaign in Uganda. My PhD has 5 objectives, and the aim is to inform research allocation decisions about malaria control in Uganda and elsewhere in sub-Saharan Africa by generating evidence on the cost, efficiency, and equity of innovative vector control strategies. So from the 5 objectives, I hope to have 3 empirical results chapters. First is a cost of malaria illness analysis. Second is a cost analysis of implementing housing modification. And third is a cost effectiveness analysis of next generation nets. And I'll extend all of these analyses to incorporate equity. So for the cost of illness, I'm going to show how I've done that using concentration curves. Today I'll show for the housing modification cost analysis, how I use descriptive statistics. And for the cost effectiveness analysis of nets, I'll talk a little bit about the process for choosing which equity informative economic evaluation method I chose. So the way I'll organize the rest of my talk is that I'll briefly talk about a component of each analysis and then highlight one way in which I incorporated or plan to incorporate equity considerations. So first is the cost of illness analysis. And this is basically completed, but very near completion. The data collection for this study has 2 parts. First, we conducted a health facility costing activity in 8 health centers. And second, we collected household cost data via household surveys. We combined these costs to estimate a societal cost per case. We used concentration curves and multivariate regression analyses to investigate how the cost per episode varies by equity relevant variables, such as geographic location, household socioeconomic status, and the age and gender of the patient. The concentration curve seen here was significantly, but only slightly below the line of equality, which indicates that richer households only incurred a slightly higher share of household malaria costs than poorer households. The essentially equal share of malaria cost burden across households of different wealth status indicates that poorer households are likely at higher risk for catastrophic health expenditure than wealthier households. Therefore, the distribution of costs is likely not equitable. So moving on to my second results chapter, the cost analysis of housing modification. And this was part of the Uganda housing modification study, where local laborers hired by the study modified 2,000 homes with screening and 2,000 homes with eve tubes. And I'm in the final stages of this analysis. So we collected data prospectively alongside the trial, and we conducted 5 household surveys throughout the trial, which included demographic data collection, including proxy indicators of wealth, such as asset ownership. Looking at the mean cost per house modified, we found screening to be $115 per home and eve tubes $50 per home, which is high compared to other malaria control interventions. However, considering the potential longer life of these interventions, these costs are comparable to the cost per person protected per year for other interventions. We collected micro-costing data on every home modified, such as the number of modifications per home, so number of windows screened, number of eve tubes installed, and this allowed for individual household level cost estimates, which we combined with demographic data to see how the costs vary with equity relevant variables. Here, we can see that societal costs of both interventions were lowest in the poorer homes and highest in the wealthiest homes. And this is because the wealthier households have bigger homes, which increase the cost of installation, more windows to screen, more eve tubes to install. We used more complex methods in the paper, but I wanted to highlight that our simple descriptive results suggest that an intervention that prioritized poor homes may reduce inequity in both disease and cost burden of malaria, and that prioritizing lower SES homes, given their lower cost to modify, could have progressive vertical equity impacts. Or an intervention that targeted all homes could be inequitable because the richer homes cost more to modify. Finally, I'll talk a little bit about results chapter 3, which is the cost-effective analysis of next generation nets. And this is where I'm in the beginning phases of analysis. So in 2020, the Ugandan government distributed nets to the entire country. And we selected 64 districts in which they distributed next generation nets instead of standard nets. And these are the regions highlighted on the map. And then this is just the decision tree that I will be using for the standard cost effectiveness analysis. So in addition to the standard cost effectiveness analysis, I'll be conducting an equity-informed economic evaluation. Since I'm at the beginning, I thought I would talk about how I framed my choice of methodology. Through review of the literature, I identified several different methodologies and analytical approaches incorporating equity into economic evaluations. To choose which of these methods is most appropriate for the cost effectiveness analysis undertaken in my thesis, I had 3 criteria for selection: data availability, feasibility and complexity of analysis, and results interpretability. Based on those criteria, I decided the optimal methods would either be a distributional cost effectiveness analysis or extended cost effectiveness analysis, both of which I'm currently exploring. And here is just an example of a busy table I used to consider data availability. So I listed some of the inputs of my cost effectiveness analysis and mapped out how they were disaggregated in my data set. Okay, so some take-home points on why and how you can incorporate equity into a PhD. First, the why. Malaria disease is concentrated in poor and rural communities. Therefore, if health equity is a priority, it's important to know who is bearing the cost and disease burden. Considering equity in these analyses help identify potential equity and efficiency trade-offs, conceptualized here by the health equity impact plane. Incorporating equity into intervention cost analysis can provide important information for policymakers to potentially target programs to vulnerable groups. And now the how. My work included different types of economic analyses, including a cost of illness analysis, and cost effectiveness analysis. It's possible to incorporate different methods in each type. There are several different ways to incorporate equity, from equity weighting to a full distributional cost effectiveness analysis, and it's important to choose the appropriate method. I did so based on data availability, interpretability, and complexity of methods. Finally, a lot of equity informative economic evaluation is done via modeling. Here, I hope I've shown that it's possible to collect primary data to inform this. However, I had the advantage of giving input during the study design phase, which was key. We were able to use existing data collection activities, such as the cross-sectional surveys, and we relied on those actually implementing the study, the local carpenters and the masons, to collect household level implementation data. Therefore, if equity is truly a priority, evaluation should be tailored to answer these questions. So thank you to the study participants, field team, investigators, funders, and my supervisors. And thank you to everyone who's joined and for listening. I know I only briefly touched on each study, so I'm happy to take any questions.
Thank you so much, Katherine, for a very nice overview. And as you may have noticed, Katherine is towards the end of her PhD. So she has been able to also show some of her results and also the challenges of actually conducting it. And James, who's just embarking on this journey, has much to look forward to. So thank you again, Katherine. We'll now move to the next part. And for that, I'll hand over to Naomi to take us ahead. Over to you, Naomi.
Thanks, Sada, and thanks very much, James and Katie. So you've heard now a couple of presentations, one from James, who's at the start of his PhD and is thinking about equity, and from Katie, who's towards the end of her PhD and has done quite a bit of work on it. So the idea is that will sort of stimulate discussion. So what we're going to do now is put people in quite small discussion groups. We're going to have just 4 people per breakout room, and just introduce yourselves, talk about the work that you're doing, and use the speakers as a sort of think piece or a stimulation for discussion. And just to say, so make sure you do some good introductions and then just chat. There are quite a few people that aren't PhD students, which is great. You're very welcome, and in particular the expertise you bring. But if you sort of as a group focus on supporting the PhD students within your breakout group, asking them open questions and exploring sort of their PhD work, that would be brilliant. So I've tried to allocate people I have allocated people to rooms, and you're going to have 20 minutes. So I'm going to open the rooms now, and you're all going to sort of disappear into those. So I'm just going to check that they're not. Oh, some people have moved. So I'm just going to quickly move so we don't have two people in one group, because brilliant, people are just joining us from the breakout rooms. Some of them are still lost in the virtual corridor, but not many, I think. So sorry, I lied. Some of you were in groups of 5, but I'm sure that you coped with that. I hope you had some good discussion. It's difficult to get it right with how long it should be. I've done 15 minutes before, and just as people are getting to the interesting bit, it ends. So we've tried 20, maybe it felt like too much. I don't know, but it'd be good to find out. So we've got a few minutes now in case people want to share any key points from their discussion group, or if they have burning questions for either of our speakers, Katie and James, we'd be happy to answer that. So feel free to put questions in the chat if you would prefer to do that, or you can just raise your virtual hand. Perhaps while you're thinking, actually. Oh, yeah, Pete's got a question. Let's go straight to Pete then.
Sorry, yeah, I feel a bit bad self-nominating to speak for our group, but I think what we landed on as an interesting one, particularly, thinking about Rachel's experience with an intervention in South Africa, is considering equity with respect to things other than income, and in particular thinking about, for instance, patient lifestyle as a dimension to consider equity against, and how that fits within paradigms of patient-centered care and UHC. So I guess my question would be, are these methods, which I don't know a lot about, flexible enough to consider equity against things other than income or proxies for wealth, etc.?
Great question. Thanks, Pete. It sounds like that was an interesting discussion. I'm going to ask, if it's okay, Stefan and Richard maybe to come in on this. And Katie and James, you're also welcome to. But maybe if we start with them.
Yeah, I'll be brief. No, thanks a lot, Pete. I don't know where you are on the screen. I saw your face. It's a great question. My quick comment is, this is 2 quick comments. One is, I think, and in fact, also in our group, we're talking about the data needs. I think that in many of these approaches, especially in settings where you have less data, I think that it can be quite difficult because it's quite data hungry. I think 2 things. One is that in many places you don't have systematic data by income, so you need to find some proxies. And then in some places we know that, right, that there are certain places that are much richer than others. And that there are some associations, correlations. Now, the other, I think, answer to your point is that I think that from a sort of planning purpose, I think it's useful sometimes to also use the data that's available in some disaggregation that is then, under the control of, the sort of decision makers. What I'm trying to say is that, say, we're talking about South Africa, which has a provincial organization. We're also talking about Ethiopia, which has more than 10 regions. Often there's discretion in terms of setting policies. And so that it's also not only that you have those data inputs by those regions, but that you also, I think are able to perhaps provide a disaggregated, information and outputs that then is relevant for decisions. So that would be my answer. I think you're in fact, actually in Cape Town, Naomi can tell you about this. We had lots of discussions like your question, which is what kind of equity? Which I don't think we came up, Naomi, with a conclusion, because of course there's different contexts and so on. And I think data is often a limiting thing. So we should always bear in mind, I think, when we embark on those analyses, that sometimes not all the data we want is available. Thanks a lot for your question, Pete.
Stefan. Richard, did you want to answer that?
I do apologise. I've got to run to another meeting, but I've just put a little response in the chat. Thanks so much for organising it. Great meeting, and we really enjoyed meeting some people. All the best.
Thanks, Richard. Yeah, so Richard's put it in the chat. I mean, we've just completed a sort of distribution of cost effectiveness analysis online course, and a lot of people were there from Australia, and they were really interested in Indigenous versus non-Indigenous populations. That was much more policy relevant for them. But then the groups get really different in terms of volume. I think it's only 3% in Australia that are an Indigenous population. So you can still apply these methods, but the results just look really sort of crazy when you just got those two bars. And the topic of unfair and fair sort of health inequalities is a really interesting one as well, which I think we probably don't have time to get into now. Thanks, Pete, for raising that. Tian Jiao, have you got a question for us?
Hi, everyone. Question from Australia as well. Can I ask if there's any plan for the next round of the DCA online course? Because I wanted to register, but it was fully booked. So can I ask for the next round? Is there any plan?
I think that they're going to do a sort of self-learning one where you can just access the lectures and all the materials in the new year, and then they're going to do another sort of taught one with the live tutorials accompanying it next autumn, I think. Something. So yeah.
Okay. Yep, self-learning one is also great. Thank you.
It's all right. So before we lose too many more people, Katie, I wonder if you could just give us a notice about mentoring.
Yeah, hi everyone. So I am one of the co-conveners for this day, and we are working on starting some sort of mentoring program. So you may have seen we sent a survey out to the members in October, and we had a great response. There's a mix of PhD students, early career researchers, and more senior that responded, and they expressed an interest in having sessions based on career progression, publishing papers, research funding, as well as technical advice. So our next step is to host our first mentoring session. So we aim to do that early next year. So just watch your email for information about that, and we'll also provide details on what the focus will be for that first meeting. Thanks.
Thanks, Katie. That's great. So we've got a few things going on as part of this group, and we're really keen to support PhD students as much as possible. So I will just say thank you to everyone, I think. Big thank you to Katie and to James for their excellent talks. It takes a lot of time to prepare talks, a lot of emotional energy to give them. So thank you very much for doing that for us. I'm sure people learn a lot from you, and we're going to, I think you're going to share your slides with Kate at iHear, and she's going to link them. So this has been recorded and it will be available publicly, and there'll also be a link to the slides, which have their contact details on as well. So do get in touch if you have further questions. And thank you everyone for joining in with that. I know, like, long discussion groups, it's quite demanding as well. You can't just sit back with a cup of tea. So I appreciate everyone's contribution and willingness to get stuck into those discussions. Yeah, so keep watching this space for our next activities as a special interest group. I think it will be probably an email from Katie regarding the next mentoring session. So, and thank you to Sauda as well for doing the intro and helping with planning this. So I shall see you all again in the future.
Thanks, Naomi. There is a quick question.
Thanks, James.
From Christopher.
Christopher in the chat.
Community wisdom and local context. My project is heavily stakeholder involved modeling project, and yeah, next week I'm talking to the Ministry of Health, NCD division, and we plan to have about 4 stakeholder workshops in Kenya to get their inputs on this. Yeah, so that's the first question. Then yeah, all the subsequent questions that you've raised, I think they are questions that will be addressed through the modeling. So we'll discuss that with stakeholders, and yeah, I may not have answers now, but happy to chat out about it outside the call. Please reach out to me on email and we can further the discussion. Thanks.
Thanks for pointing that out, James. That's really helpful. And I think there's a question for you also, Katie, in the chat. I don't know if you've had a chance to have a quick read.
Yeah, I'm also happy to discuss more over email, but I'll quickly try to respond to a couple of these questions. The first was, how did you address the potential spillover effects and externalities of your interventions on the neighboring communities and countries? So it was a cluster randomized trial, and there was definitely buffer zones between for the housing modification. And then for the NETS trial, as I said, Uganda distributed NETS to everybody. But again, the areas that had different nets, these next generation nets, were not directly next to where we measured malaria incidence, were not directly next to each other. So there's buffer zones in both cases. I think the second question I can't answer yet because I don't have effectiveness data for either trial. So pending. I'll be doing a full cost effectiveness analysis for both the housing modification and the nets, but effectiveness is not in yet, so pending. Hopefully there isn't a trade-off, but hopefully they're both good for equity and good for effectiveness. And then how do you ensure that your economic evaluation reflected community wisdom and local context? So I can speak for the larger trial. We directly involved the community. We started with the pilot project, and all of the input we received from the people living in the homes, the local leaders, the National Malaria Control Program, we incorporated when we did the full rollout of the larger trial. And then as far as my specific economic evaluation or economic analyses, I work hand in hand with the National Malaria Control Program here in Uganda. So sort of my outputs are tailored to answer the questions they need to know to move forward with malaria control policy. So I hopefully address that.
Yeah,
but I'm happy to continue over email.
Yeah, that's great. And just to mention that, Chris, my modeling project, I'm yet to do conceptual modeling. So most of the questions will be addressed, but to let you know, I'll do, the analysis will be based on, from a health system perspective at the very least, and most likely, because I'm incorporating bits of household costs, so I'm thinking about a societal perspective. But most of that, we are happy to discuss the technical bits outside the call. Definitely I'll reach out on email. Thanks.
That sounds great. Thanks, Katie and James. And thanks for those really challenging and in-depth questions, Christopher. That was really helpful. So I think, let me know if I've missed anything else. There's a few people called Naomi because I accidentally sent a link to lots of people writing in the chat. That isn't me, but anyway, it doesn't matter. It's all a bit confusing. We have run over time, so I think we'll close it there, but do get in touch with James or Katie if there's anything further you want to discuss with them. Just mute that rogue Naomi. And it's been really lovely. Thank you for your questions. Thank you, everybody. Thanks again, James and Katie. And I'll close the meeting now. Bye, everybody.